Hi, I'm Dr. Kaitlin Mahoney. I work in the Southwest offices, currently here in the Christiansburg office. Today we're going to be talking about tendinopathy and other tendon conditions. So tendinopathy is a term that not everyone has heard before, but I'll start by kind of explaining what a tendon is. So in this picture up here, you can see on the top of the screen, there's a pink structure that's supposed to be muscle. And then on the bottom of the screen, the floor of that picture is bone. So where the muscle attaches to bone are tendons. So the thing that kind of looks like a beehive on the left side of that picture is microscopic view of a tendon. So the most common form of tendon injury that people know of is tendinitis, where there's acute inflammation. And then tendinopathy is thought to be chronic inflammation. So there's inflammation that just will not settle down. There's continued stress, the tendon. So the tendon starts to have kind of a poor, unhealthy environment. It starts to lose blood supply. And instead of being these beautiful, tight cables, it will just kind of look nasty and mushy, and it's not as able to tolerate forces through it. So it gets irritated more easily and it just hurts. So that's that. So very common areas where we see a lot of tendon issues. So the picture all the way on the left is showing all of the structures in the front part of the knee. So if you've ever heard of or had pain right underneath your kneecap, that's your patellar tendon. So in very young athletes, we'll see a lot of patellar tendinitis. So pain in the front of the knee with jumping. We also call it runner's knee or jumping knee. And then as that pain continues, it just did not settle down, then you could have chronic patellar tendinopathy. And it's just disorganized, thickened tendon, makes it really hard to bend the knee, do stairs, jump, run, all of those sort of things. The next picture, so one over to that, is showing the front part of the shoulder. So one of the most common areas in the shoulder we see tendinopathy is in the biceps. So people will have pain in the front part of the shoulder. I see that a lot with people who work on a desk or do a lot of forward motion all day. The X-ray picture is showing the back part of the heel. So a lot of people know that as bone spurs or enthesophyte. So what that's trying to depict underneath the arrow or above the arrow is where the Achilles attaches. So the Achilles is what causes your toes to point down. It's where when the calf muscles engage, you'll have traction through that tendon, and chronic tendon dysfunction will cause thickening and then calcification in that region, and that's where you'll get that bone spur. So often we'll see a patient who says, I'm here because I have a bump on the back of my heel and it hurts. That's typically what we're working with there. And then probably the most common thing that gets people to come in is lateral epicondylitis. So typically no injury, just a lot of vague, achy pain right on the outside of the elbow. It will hurt when you're driving in the car, try to pick up your water, pick up a cup of coffee. Usually this happens after a lot of repetitive tasks, such as hammering or mixing or like holding a baby or just life lifting repetitively. So this is kind of showing pictures of how it presents. So usually there's no drama to it, it just hurts. So gradual loss of function as well as pain. And we're kind of shifting more towards this chronic tendinopathy now. It will feel stiff. Some people say like it feels like it pops. A lot of times as you stretch it out, it will really hurt. Usually no injury, like I said, but a lot of times related, there's an increase in activity. That's actually not always the case. The Achilles actually happens a lot from no change. Sedentary activity, the tissue just is irritated. So the first picture all the way on the left is showing kind of tennis elbow. We don't see it as much from tennis as we do from like regular day-to-day activities. A lot of times people will say they go to sleep at night. Most of us sleep like this. That first stretch out in the morning is just awful. The second picture, she's grabbing the top of her shoulder. So there are a ton of tendons up there that can cause a lot of dysfunction and achiness. So you see a lot of patients who just be like, this whole thing really hurt. The next picture, I was showing the hammer. So hammering is a repetitive activity. Doing that through a lifetime can cause tendinitis of the wrist or the elbow. And then that last picture, all the things in the front part of the hip and the knee that can cause pain. Tendinitis in the psoas muscle or the hip flexor, or the patellar tendon being probably the most common ones that we see in that area. So there's a lot of risk factors. Some of them are vague. So having a history of tendon dysfunction or tendinopathy puts you at risk for further tendon issues, which unfortunately there's not much you can control there. Age over 35, which is pretty young for most conditions that we see. Different body mechanics. So in the skeleton picture on the top, that's kind of showing the subtle differences between pelvis in a man versus a female pelvis. So a female pelvis is wider, and that mechanically puts additional stress on the side of the hip. So I see a ton of women with side of the hip pain related to gluteus tendinopathy. Really, really awful, painful condition, makes it hard to sleep or walk. Muscular weakness, like general muscle atrophy or fatigue, puts you at risk for tendinopathy, and we really need a strong muscle to have strong tendon. And with time, our muscles atrophy unless we're training them. So having weak muscles does put you at risk. People are usually like, oh, I'm not going to do this exercise because I don't want to hurt myself. But fear of using your muscles can actually cause pain. There are genetic predispositions for tendinopathy. Pretty complicated stuff. Can't really control for that, unfortunately. Overtraining can do it. So like super heavy endurance athletes or overtraining in life. So people who do a lot of cleaning will have more at risk for tendinopathy, or cooking, painting, hammering, anything where you are doing the same thing all the time. It's a lot of additional stress through that tendon, as well as poor ergonomics. So that bottom picture on the right is showing what happens when we're on our cell phone, which is not great for the way that our skeleton was designed. And that causes a lot of fatigue and overstretching to the upper back muscles. And when those get overstretched and weak, it puts a lot of stress on the front muscles. And then we'll see like facet tendinitis from that, and rotator cuff tendinopathies and pec issues, just because we're not using those upper back muscles the way that they were designed. There are a lot of medications that can contribute to tendon issues. So statins for cholesterol can increase your risk. There's a few antibiotics that can increase your risk for tendon issues. And then also metabolic diseases can contribute. This is kind of a newer concept. It wasn't really studied for a while, but recently we've realized the role that diabetes has in tendinopathy and other inflammatory conditions like inflammatory bowel disease or gout. Also, that total body inflammation does put you at risk for tendinopathy. So how is this diagnosed? A lot of times it's clinical. So pain over the tendon in most cases. Some tendons are really deep or hard to put pressure on it, but for the most part, it hurts when you touch it. Sometimes there's swelling. In the Achilles, you will see thickened tendon. It's very visible for most patients. And then it will hurt when it activates the muscle. So if you're dealing with the elbow, it hurts when you engage those muscles. If it's on the shoulder, it hurts when you kind of use the shoulder. Sometimes we'll get x-rays to take a look at the joint and see if there's anything else globally going on. A lot of times on the x-ray, you'll see that little bone spur and thesophyte that I brought up earlier on there. The picture on the bottom right is of an MRI trying to depict a bright white thickened Achilles. And then an ultrasound is another study that I use a lot in my clinic. It's kind of fun for me to show the patient what happens when they engage that muscle. The arrows in those pictures are showing these like bright white signal throughout the tendon. So what we see a lot is microscopic tearing to the tendon, and the body will kind of put down calcium deposits to stabilize that. And you'll see these little deposits within the tendon, and they typically correlate with a lot of pain and inflammation. And that chronic inflammation and irritation will just cause the tendon to become thick and very, very weakened. So in terms of treatment, one of the main things people usually try before coming here is modifying the activity. So it hurts when I do this, so I've been trying not to, which is not always possible because a lot of times it's related to work or something you have no choice of doing in life. But if you're able to correct the mechanics on the way that you're doing things, it can help a lot. A lot of times we'll use bracing to restrict the motion through the tendon. We'll put you in a walking boot to take some pressure off, or use crutches. All things like that can make the pain a little bit more tolerable. Like we talked about earlier, when it comes to tendon, the most important thing is strengthening the muscle. So that's why physical therapy is pretty critical for this disease process. So if you're able to make that muscle stronger, it kind of propagates down that tendon, makes that tendon more resilient, and helps with overall pain. It is frustrating because it is not a quick fix. It can take 6 to 12 weeks in therapy before you really feel back to your normal self. That's typically the best investment in most cases. Anti-inflammatories can be used in the short term to help with pain temporarily. It's not so much of an acute inflammatory process once it gets to this tendinopathy, but with that nighttime ache and that sort of pain, it could help a lot. There are a lot of different types of techniques and injections that can be done to help with pain. The standard one that most people know about is a steroid. So the reason why steroids are injected is because they could decrease inflammation and help with pain. When we're dealing with chronic tendinopathy, that pain relief oftentimes is relatively short-lived, so generally a couple weeks of pain relief. And if it's not combined with therapy, it does tend to come right back. And then there are certain tendons that are just way too dangerous to mess around with the steroid. So that's something to consider. Steroids can increase your risk of tendon rupture, and that is not something that we want to do. So that requires a lot of decision making. Injection technique that is also really common if the other things are not working is a tendon fenestration. And that's kind of what that bottom right picture is demonstrating. So you could actually take a needle and kind of stab at that tendon to bring blood flow to the area and encourage healing. That technique shows a lot of promise. It sounds awful, but generally it's combined with a local anesthetic to reduce pain. And you could either do that with numbing medication, or you can add a injection in there called PRP, or platelet-rich plasma. So that's drawing your blood, getting your platelets, and injecting the platelets back into the diseased tendon. Platelets are like your body's first responder when it comes to healing. So they have the capability of creating a local inflammatory response, trying to kind of go back in time, make it go back towards that tendinitis to encourage the tissue to settle down and heal, bring blood flow there. And that's a procedure that's very promising, not as fast as a steroid, but for the long term is so much better. So those are tools that can really help if the basics are not working. And then ultimately, some cases do go on to surgery, especially cases where the tendon gets so weak and so terrible that it ruptures. And that's where we consider surgery for a lot of those tissues. So that's all that I had prepared. If there are any questions, this is my dog, Bruce.
Thank you so much. If you are watching live, you are welcome to put some questions in the comments now. We will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will get through a bunch of them. So our first question is plantar fasciitis a type of tendinopathy?
So it's the tissue quality is a little bit different than a standard tendon. Fascia is more fibrous. However, it is very, very similar in a few ways. The plantar fascia is very closely related to the Achilles. In a lot of cases, they both are involved. The initial treatment is very, very similar for both. And you kind of have to do the same exercises for them both to get healthier.
Thank you. Would dry needling help treat tendinopathy?
Yeah, so dry needling has become a lot more popular in the physical therapy world. Dry needling is very similar to what I was describing with the tendon fenestration procedure, just with a smaller acupuncture needle. So that's a procedure that a lot of patients all put on their PT script for them to consider. It definitely can help with pain in the short term, help make the therapy a lot less painful.
Thank you. Do any medications like statins contribute to tendinopathy?
Yep, we touched on that before. It can. Of course, it's worth a discussion with your doctor if it's safe to stop. It's also been studied where if patients are able to control their cholesterol and come off the statin, the effect of the statin is typically only happening while on the medication. So if you're able to come off the medication safely, the tendons do have the ability to recover from that.
What steps can you take to help prevent tendinopathy?
Staying active, but of course not too active. I usually tell people when they're introducing a new exercise to take it slowly, about 10% per week of intensity and volume increases, making sure that you're eating enough protein and carbs to support your muscle growth and staying mobile, staying healthy, making sure that you're balanced so you're not only doing biceps and forgetting the triceps, that sort of thing. So total body health and really staying active.
How long does it take tendinopathy to heal?
A long time. That's the frustrating part. I usually set the expectations at the initial visit that the therapy portion of it or the exercise portion of it can take 6 to 12 weeks. In some cases longer, like we keep going back to the Achilles. It's really hard not to use your Achilles when you walk or stand all day. So that condition can take 16 weeks of physical therapy. Similarly, the tennis elbow or the lateral epicondylitis, just with how much we use that tissue during the day, the pain from that condition can take up to a year.
Can tendinopathy be mistaken for arthritis or other conditions? How do you tell them apart?
Yeah, and a lot of people have a little bit of both. In our office, we get x-rays on a lot of these complaints to evaluate the joint, and that can effectively tell us if there is also arthritis present. There are a lot of similarities. The tendons attach around the joints, so that is distinguishable based on the combination of physical exam and x-ray. But the presentation is similar to both, so it is hard for a patient to know what they're dealing with without some help from our end.
Thank you so much. That is all the questions that we have for today. Dr. Mahoney, would you like to close?
Nope, just the information on how to schedule an appointment is on the bottom. We have online and scheduling by phone. Just give us a call if you need anything. Thank you so much.